This is a really cool image, Gunther and everybody else, of a fetal MRI. This is a 20-week fetus. And you can see the features of a cloaca here.
Yeah.
You can see in the middle is a hydrocolpos, even in a fetus. And why is the hydrocolpos developing? It's because urine is not able to get out of the perineal orifice and goes back into the vagina, making a hydrocolpos, which is a problem because it can cause hydronephrosis by obstructing the distal ureter. And that's why, not uncommonly in a prenatal ultrasound, you can see bilateral hydronephrosis. That's why when the baby is born, you need to intervene. All right, next slide. All right. What do you think this is based on my previous discussion? I want to be able to see the picture. Very good. Mohammed, thank you for putting in the questions. That's beautiful. I will say that is mapsuta. Okay, so we see a single orifice. So it has to be a cloaca, but a very strange right. The hole is very posterior. The hole is where the anus would normally be, and there are no other holes. So the correct answer here is a posterior cloaca. All right, next slide. Okay, so here is a newborn with the hydrocolpos. The same baby that we showed you as a fetus has now been born, has a very large pelvic mass, which is a hydrocolpos. And another baby on the right is a baby that has what appears to be like a prune belly. Why could a baby with a hydrocolpos in utero develop a prune belly? And there are two potential answers. What do you think? Anyone want to say? You have to unmute. We have to unmute whoever wants to say.
Raise your hand if you want to comment.
Yes, if you raise your hand, then Mohammed can unmute you. If we unmute everybody, then the sound will go crazy. Well, I don't know. Are there anyone interested in speaking, or you want me to give the answer? So if you have a very large abdominal mass in utero, that can obviously stretch the abdominal wall, and a hydrocolpos can do that. But the other interesting thing that maybe you haven't thought about is once the hydrocolpos is filled with urine, there is a way for the urine to exit. The urine can get out the fallopian tubes and cause urinary ascites. And on those grounds, the patient can develop a very dilated abdominal cavity and be born like they had prune belly, similar to a valve, a urinary valve situation. Next slide. This is the most impressive hydrocolpos in a newborn I've ever seen. Look at that. Like the entire abdomen is filled with the hydrocolpos. You have to intervene here. You have to put a catheter in the perineal orifice and try to decompress this. Most of the time you can successfully decompress this with irrigations through the perineal orifice. Sometimes you need to do a formal vaginostomy, either with a tube or like a G-tube, basically like a vesicostomy, but into the vagina. Next slide. Remember, by the way, if you have a hydrocolpos, About half the time it's bilateral. So if you are going to drain the hydrocolpos, you must drain both sides. So if you're going to open the vagina at the dome, you need to remove a little bit of the septum so that both sides can be drained by one maneuver, either with the tube or suture. I've seen patients that have had interventional radiology drain only the one side, and then the other side, the hydronephrosis, does not improve. In this picture, you see hydronephrosis before and after drainage of the hydrocolpos. No intervention of the urinary tract was required. Really, really important. A lot of babies, if they're dealt with by a urologist, might undergo a vesicostomy. And a vesicostomy does not readily solve the problem because the fluid is in the hydrocolpos, not in the bladder. In fact, the urine can't get to the bladder because the ureters are blocked. You have to drain the hydrocolpos first, then the ureters are no longer obstructed. Now the bladder can fill and the hydronephrosis will go away. Next slide. So here are some artistic diagrams of hydrocolpos on the left and a reminder that about 50% of the cloacas have a bilateral system, which you can see on the right. Next slide. And here is a massive hydrocolpos, and you see on the right side, I have cut into the dome of the vagina and removed a little bit of the common wall and then closed it back up. And then you can drain that with a tube or a sutured vaginostomy like you would a vesicostomy, and then you have control of the situation. Next. All right, now let's talk about the reconstruction. And now we can really get to the thought process behind the case that Mohammed presented. The picture on the top on the left is a very short common channel cloaca, and the one on the right is a long common channel cloaca. And I want you to also look at the length of the urethra above the common channel. Does anyone want to say what they predict the length of the urethra is in these two circumstances? Raise your hand and then Mohammed will unmute you. No one? Anyone want to say? Groove Ghosh.
All right. Hello, Mark, everyone. The relationship should be reciprocal. The longer the common channel, the shorter will be the urethra above the common channel.
Yes, that's very correct. That sounded like my friend Sammy. Is that true?
Yeah, right.
Sammy, I can recognize your voice now.
Yeah, sure.
I think Dhruv Ghosh had a question or wanted to comment. Can you unmute him? I'm looking. He looks still like he's muted. Mohammed, can you unmute him? Dr. Ghosh? He's waving. Kif khalak? Oh, okay, you're unmuted.
Right, thank you. Yeah, no, I concur with what the previous speaker was saying also, as well. Something happening. Anyways, can you hear me?
Yes.
Yes.
All right. The other thing that I was sort of wondering, the longer the urethra, especially the picture on the right of the screen on my left, would suggest that the length of the urethra would probably give slightly better continence post-operatively, urinary-wise. Is that something that we consider?
Yes. So when these pictures were drawn, the concept of the importance of the urethral length was not talked about. The only thing that was talked about was the length of the common channel. And I learned after taking care of many of these patients that actually the most important determinant of continence is the urethral length, not the common channel. And as Sammy said, the relationship is reciprocal. The longer the common channel, the shorter the urethra. The shorter the common channel, the longer the urethra. Therefore, a total urogenital mobilization, in my opinion, is only possible in a relatively short common channel because you are confident that above your mobilization, you have an adequately long urethra and you have minimally disrupted the urogenital confluence, the so-called urogenital diaphragm. You do not want to pull that down and create urinary incontinence. So the decision about surgery is based on the common channel length and the urethral length. And in my opinion, if you cannot guarantee at least a 1.5 to 2 centimeter urethra, you should not do a total urogenital mobilization. Now, there are rare cases that have a short common channel and a short urethra. And in such a case, I would do a urogenital separation. More likely, there's a long common channel and a short urethra, and then for sure, I would do a urogenital separation. Let me show you some examples of that. Next slide. So here is a beautiful cloacogram. And by the way, Mohammed has been working very hard on making these beautiful images using MR. And I think his thesis will be based on this information. And you can get a very nice image by MR, but remember with MR, you need to make sure the structures are distended. If the structures are not distended, you will not get accurate measurements. This is done with fluoroscopy with a 3D reconstruction, but I believe that MR is the future, but we need to be able to distend the structures. So this is a really interesting patient. Does anyone want to comment on what you see here? Don't be fooled. This is a trick case. This is a very sophisticated audience, so I put some crazy slides in here. I don't want Munther and Sammy to be bored.
Okay. Dr. Amr?
Yes, hello, Dr. Mark. Hello, Muhammad. I'm Amr Abdelhamid, Ain Shams University. I think this case, the rectum is in between the vagina and the bladder.
Mabsut Hamdulillah. That is right. Now, where are you? Who spoke? I want to see your face.
Yes, I'm Amr Abdelhamid from Ain Shams University.
I'm trying to find you. We have so many people. I want to look at who you are.
The video camera is off, I think.
Oh, his video's off.
I'm not putting the video.
Who is that with you? Mustafa Abdelati. Is that Todd Ponsky in your picture? My friend Todd is with you, looks like. Is he with you in Alexandria? Mustafa.
Yeah, originally from Alexandria, but now in England.
Okay, so yes, the rectum is in the middle. That is correct. And the interesting thing about this picture is that thank you. Julie is telling me that I should have said Mabruk. Mabruk is better. That means congratulations. Mabsuta means I'm happy. So yes. I'm happy, Mabsuta, but I'm saying Mabruk because it's an excellent answer. Is that correct, Mohammed?
Yes, that's correct.
Okay. By the time I come to Alexandria next year, I will be fluent in Arabic, okay?
You have let it.
All right, so let's look at this picture for example. Let's see here. So can I control can you see my pointer?
No.
I'm going to take over your screen. I wonder if
I can stop the share and sharing from your side.
I wonder if I can take your screen.
No.
All right. Anyway, Mohammed, you can do it. Show the length of the urethra.
From brother neck.
Yes. Down, 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 down. A little bit more, a little bit more. There. Good. So that's a good urethra. And then from that point down is the common channel. Does everyone see that measurement? All right. Let's go to the next slide because there's some more examples of this. All right, this is beautiful, right? Now this is a more typical cloaca with the rectum in the back.
Mm-hmm.
But this is the kind of case that I think Sammy was referring to, where there's a long common channel and a relatively short urethra. This is the kind of case that I would do a urogenital separation. I would not do a total urogenital mobilization. Is there anyone that disagrees with that? Is there anyone that agrees with me? Nobody? Sammy? Yes? Okay. Sabir? Sabir,
I do agree, Mark.
Agree? Okay.
Yes, Munzer, I do agree.
All right. Munther, you always agree with me anyway.
Most of the time.
All right, let's go to the next slide. Okay, now we have a challenge. Which of these is appropriate for a urogenital mobilization? So just so you know, we have 128 participants on this call. 128. The first week we had 70. The second week we had 85, and now we have 128. Either it's getting more interesting or people are more bored. Okay, so Dhruv Ghosh says the first one is amenable to a urogenital mobilization. I agree. The common channel looks to me about maybe 1.5 centimeters, and the urethra is at least 2, maybe even 3 centimeters. What does everyone want to do with the one in the middle? The middle is tricky. See, in my opinion, the middle one would be a good case for a separation. You could probably do a total urogenital mobilization here, but I would be worried that you would pull down the bladder neck and the patient would leak in the future. So I think this is a case for a urogenital separation. And the third case for sure needs a urogenital separation. Let me show you the next slide. Mohammed went to, maybe he's wanted me to show this because this is a really cool picture that you can make from your 3D reconstruction. The radiologist can make a color. They can choose colors. And you see here that there's and I think this should rotate. Can you play the video? Does this, or it doesn't work maybe?
Doesn't work.
Okay, that's okay. Go back one slide. Now, okay, advance that slide. All right, now this is a study that we did that we took normal children that were having a VCUG because they had a urinary tract infection. And you see here that almost every girl has a urethra at least 1.5 centimeters in length. So if you cannot guarantee a 1.5 to 2 centimeter urethra, you should not do a total urogenital mobilization. All right, next slide. This is a really cool picture. This is a really cool picture of a mobilized vagina that did not reach. And in its place, we are putting a segment of colon for our vaginal replacement. Can everyone see the fallopian tubes, the hemiuterus, and the vagina in the middle? And then we bridge the gap with a piece of colon. You can see the suture line. Isn't that pretty? All right, so sometimes the vagina reaches by itself after you've done your urogenital separation, and sometimes you need to do a vaginal replacement. Next slide. But I think the future of this field is probably in tissue engineering. I hope one day we can have a vagina made from the DNA, from the cells of the same patient, grown and given to the surgeon 3 months later to be sewn in, so we don't have to do vaginal replacement. Next slide. Okay,
We can
now let's go back to your case. By the way, all of these slides are available to you. Mohammed can send them to you.
Okay.
All right, so the one thing I didn't see in this particular patient is the measurements on MRI. Do we have those?
Now, no, I didn't have.
All right, but go back to the slide. Go back to the slide that said the measurements, the numbers. Okay, so I agree that this was a case that would benefit from a urogenital separation, although I will tell you, to have a common channel of 2 centimeters is relatively short. Most of the time, the urethral length is longer. So now you have a situation where you've done a urogenital separation, you've reconstructed the urethra, and you have a fistula. What do you do? Anyone have opinions about this very serious complication? And by the way, the reason why the total urogenital mobilization was created was to avoid this exact complication, because you don't have to separate. Anyone have any opinion about what to do with this girl who has a vagino-urethral fistula?
Dr. Amanda?
There are 2 participants raising their hand. The brave ones.
Yes, Dr. Sam?
Yes, Mohammed. Of course, this is a difficult case, challenging case. It needs Marc Levitt or someone of the experts around in the audience. But basically, you need to redo the separation and put soft tissue interposition to avoid recurrence. This is a very difficult undertaking, and we need to think about the approach, how we are going to approach this. Transabdominal or redo posterior sagittal, which is, I believe, will be very difficult.
I think, well, first of all, let's say, first of all, we need to prove that there is a clinically relevant fistula, because there are some patients that I think if the fistula is distal to the bladder neck, the only thing that is a problem relative to this fistula is that the patient might have some vaginal voiding. But many such patients can void well despite the fistula, and they will remain dry. And if that's the case, it does not require an intervention, because an intervention is very significant surgery. And one nice trick is you can have the patient sit the opposite way on the toilet so that the vagina empties of all the urine. And you might be able to make such a patient dry without a redo surgery. Only if the fistula is distal to the bladder neck. If the fistula is right next to the bladder neck, it will probably be a problem with urine collecting in the vagina or leaking after voiding. And so I would basically determine whether the patient needed a redo on those grounds. Now, the thing to do for a redo is exactly what Sammy said, and that is to remobilize the vagina off of the common channel, repair the common channel. You need to put something there. A very nice thing to put there is ischiorectal fat. If you know, from the ischiorectal fossa, you can bring in fat. That was traditionally called the Gonzalez hernia. Does everyone know the term Gonzalez hernia? It's a very funny story, actually, because Alberto had a resident named Gonzalez, and he had a lot of trouble keeping in the midline during his PSARC. So Alberto named the hernia after Gonzalez, which, by the way, when you're in training, you don't want anyone to name something after you. It's usually something bad. Anyway, 25 or so years later, I was operating in Ethiopia, and I had no tissue to cover a rectovaginal fistula, and I saw the bulge of the ischiorectal fat. And I mobilized it, keeping it on a pedicle, and it was a beautiful way to repair the back of the vagina. So we wrote a paper on the ischiorectal fat pad, and we called it the Gonzalez hernia revisited. And I found Dr. Gonzalez in Mexico, and I asked him if he'd like to co-author the paper with me, and he said yes. So he's an author. So 25 years later, he was redeemed. You like that story, Sammy, I think. Okay, so what I would do here is I would remobilize the anterior wall of the vagina off of the common channel, repair the urethra over a catheter. I would probably also use something like SIS or some bio film. I'm not sure what product you guys would use there, but there is a matrix that you could put on the back of the urethra. Do you have a product that you use maybe for hypospadias repair, or what products would be available in Egypt to put on the back of the urethra? We would use SIS.
No, we usually use a second layer from the surrounding structure.
Yes, okay. And then on top of the SIS, I would put the ischiorectal fat. And then what I would probably do, because I bet that the vagina now doesn't reach, probably will need a vaginal replacement. And then the smooth colon of the replacement would also be on top of the previous fistula. And that's the way to make such a repair. And in order to get access to that location, you have to remobilize the rectum and then put the rectum back. So it's a very difficult problem, but I would definitely do it before I close the colostomy, to answer your question. And then, because you may need to go into the abdomen. By the way, one really nice trick, when you go into the abdomen for vaginal replacement, you can use the proximal colostomy, pull that segment down for the neovagina, and then make a new colostomy just proximal to the segment that you pulled down for the neovagina, putting it in the same colostomy site. Because I really like the left colon. I like the left colon for many things. The left colon is very good for vaginal replacement, and it's very good for esophageal replacement. Some of the topics that were covered by your team, the Alexandria team, in at the WOFAPS meeting. All right, what questions? There must be many questions. We talked about Ahmed Kairi has a question.
Yeah, hello. Yeah, hello, Mark. This is Dr. Khairi from Alexandria. fistula, you raised only the issue of continence. What about the issue of UTI, recurrent UTI? Because I had a case like that with low fistula, and the presentation was mainly recurrent UTI.
Yes, I think you're right. Continence and UTI would be the indication to do surgery. If the patient's having recurrent UTI, it could very well be due to the fistula. I agree.
Even if it's low.
Yes, there must be somehow contaminating of the urinary tract. Of course, I would want to know what are the urodynamics? Is the bladder successfully emptying? Maybe it's not the fistula. Maybe the patient needs intermittent catheterization. However, could they do intermittent catheterization with a fistula there? Those are the things you need to analyze and decide whether the patient needs a reoperation.
Good.
Other questions? How do I see this chat? There's according to this, oh, here we are. I'm looking at the chat. Okay, Morsi Hani says, which approach, perineal or posterior? So I like to do, the answer to your question is I like to do the redo prone, posterior sagittally, mobilize the rectum out of the way, work on the urogenital complex, and then probably go into the abdomen to pull down a segment of vagina. That's what I would do. I don't really like doing this in supine position because I find prone is a lot easier.
Dr. Levitt, this is Dhruv. I work out of India and Oman in the university hospital here. The question is about the prenatal MRIs that you do. Just wanted to know in which conditions in cloaca, on which grounds you go on to do a prenatal MRI. Do you do it for all cloacas or the ones that are really complicated? And do you do any prenatal interventions if there's a severe hydrocolpos, etc., and with severe hydronephrosis in these?
Those are great questions, and I really like your haircut.
Thank you. It's actually don't have hair, that's why the haircut.
Yep. But by the way, look, my wife did my haircut this time because all of our haircut places are closed. But she did a good job, don't you think?
Yeah, you're lucky. My wife doesn't want to have anything to do with my hair.
Okay, so the fetal MRI was done in response to an ultrasound that showed a cystic mass. We were suspicious that maybe it was a cloaca, and in fact it was. So I don't think there's any special MRI protocol for cloaca, but I think if you have a cystic mass in a female and have any other associated things, maybe a single kidney or hydronephrosis visible on ultrasound, you could be suspicious that it would be a cloaca. And then a fetal MRI is a very helpful study for the fetal discussion. Now, would there ever be a situation where you'd have a fetal intervention? There are some case reports of drainage of a hydrocolpos similar to drainage of a dilated bladder in valves. I think I know of 2 case reports. I think the only time you would ever do that is if you had hydronephrosis and hydrops. Otherwise, I think it would be too risky because many of these babies make it to term, and then you can intervene, and the hydronephrosis goes away within several weeks. Of course, we all know that some of these babies are born with renal failure. Luckily, that's very rare. But if there was such a case that you were worried about serious hydronephrosis and renal damage, I could see that would be an indication to intervene with a drainage. So Haithan Badawi is asking, when do you decide on Mitrofanov bladder neck closure? Very, very good question. Basically, you want to give the child, I think, an opportunity to have a usable urethra. And if you can get the patient a urethra of 2 or more centimeters without disruption of the of the urogenital diaphragm, that is a patient that likely will be able to void. And if they can't void, they can do intermittent catheterization. So I would hesitate to close the bladder neck. There are very few cloacas in whom the bladder neck should be closed. Very few. However, there are some. There are some that have essentially an atretic urethra. If there is not a reconstructible urethra, then you have to close the bladder neck and do a Mitrofanov later. But most of the time, there is a reconstructible urethra, either because you did a successful total urogenital mobilization or you did a urogenital separation and the entire common channel becomes the urethra. Okay, I want to answer Morsi Hani's question about cystoscopy. So we did a very nice study, which Mohammed can probably give you the reference for, that compared cystoscopy with cloacogram. Now, it was a fluoro study, the cloacogram. I bet you MRI is even going to be more accurate. Right, Mohammed? That's going to be your thesis. But cystoscopy is inherently inaccurate. It's close. It is definitely close. And if you have a very careful technique and you particularly have to have measurements, one nice trick is to use a urodynamics catheter, which has little marks on it. And then you can measure the length of the urethra and the common channel, and you can get a very good measurement cystoscopically. We always do cystoscopy, don't get me wrong, but the contrast image or the MRI image, but right now I'm using contrast, gives you very precise measurements. And I showed you the pictures. I mean, it's really, I can tell you since we started measuring cloacas in this way, my plan going into the operation has been the plan that I executed. Before these measurements, in the days that I was doing many of these cases with Alberto, every case was a bit of a mystery. And we didn't really know what we were going to do until we were there. And I have tried very, very hard to remove the mystery away from cloaca. Because I think if it's going to be a complex case, don't do the case unless you have experience. If you do not have experience with a urogenital separation, don't do it. Have someone help you who knows how to do that. As opposed to a straightforward case like a urogenital mobilization case, if you feel comfortable, great. But then you know the anatomy before you start. You won't make an intraoperative mistake having started a case and finding that it's much more complicated than you understood. And I think if you get proper measurements, that won't happen. So, there's a question. What do you do for those with associated sacral malformations? Because continence of both urinary and fecal will be questionable. Yes, of course. So from a sacral and spinal point of view, if you give the child an adequate urethra, almost all cloacas have a good bladder neck. So if they cannot void on their own, they can at least be dry with intermittent catheterization. With regard to stool, if they're not continent for stool, those are patients who might very well need a Malone.
Mohammed, may I have a comment?
And have antegrade flushes.
Hello?
Yes, go ahead.
Hello, Mark? Can you hear me?
Yes.
Yeah, I have two questions really for Mark. First, curator in the vagina. So do you do this? Do you do repair during the same procedure, or do a separate procedure for this problem? The other thing, what do you think about partial urogenital mobilization? Partial urogenital mobilization, because this is another way of separating the urethra from the vagina, or does it always mean abdominal operation?
So I didn't really understand the first question. I think the first question, I would do the whole cloaca at the same time. Rectum,
Topic ureter. Ureter, ectopic, vagina.
Ectopic ureter in vagina.
Ureter opening in the vagina, ectopic ureter.
Ectopic ureter?
Yeah, case where the ureter is opening in the vagina, not in the bladder.
Yeah, so
We have a case like that.
sometimes, very rarely, you need to separate the ureter away, and then you could either reimplant it or do a cutaneous ureterostomy and then do a reimplantation later. But yes, sometimes during the dissection, you need to separate the ureter. Very rarely, but sometimes, and it's an important thing to know about in advance. The answer to your question is you don't always need to go to the abdomen. You can sometimes do a urogenital separation and pull the vagina down and not go into the abdomen, but it's very rare. I just wanted to introduce everybody. Several members of the team are on. Our nursing team has joined us. We have Julie here. I see Justine is here. Tara. I think Megan is here. And Katie. So you will please welcome them. Nurses who want to know about cloacal reconstruction are very special nurses.
Yes. We have a comment from Dr. Saber.
We have some time for some more questions.
Please.
Yes, Dr. Saber.
Mohammed. Hello, Mark. I have Saber Wahid from Alexandria. I have 3 questions related to the case Mohammed presented.
Yes.
One for how much, when the follow-up of the case, usually I think the soiling from the urine coming from the vagina, but the kidneys is okay. There is no urinary tract infection. When we are going to try to close this fistula, are you believe in repeated vaginoscopy with thermotherapy, laser thermotherapy, and fibrin glue in frequent sessions before anterior mobilization for dissection? This is number 1. This is the first question. Second question, are you believe in there is a relation between the morphological picture of the ambiguous genitalia or the cloaca from outside? Is it related to the length of the urethra or the technique which might found after investigation and at the time of operation? The third question, what is the type of colostomy you prefer to avoid many troubles at the time of management or surgical management of cloaca?
Okay, I'll answer the first and the third question. I didn't quite understand the second question. The first question, I don't have any experience with laser or fibrin glue. You certainly are welcome to try. I have seen patients in whom it has been tried and the fistula recurred. But of course, it's a lot less serious of surgery. So if that works, congratulations. But I predict it won't work and vaginal mobilization will be necessary. As far as the colostomy type, my personal preference is the very proximal sigmoid so that the distal sigmoid can be used for the rectal pull-through. If sometimes you need a vaginal replacement, my preference is to use the left colon, as I said, and then make a slightly more proximal colostomy a little higher in the left colon. Can you help me understand what you want to know for the second question?
Yeah. The second question is when you are going to examine a case of cloaca in unit, there is a special type of morphology of the external genitalia. Is it hypoblastic labia? Is it in the form of skin fold, only skin fold? As another case, as you mentioned, the posteriorly located orifice of external sign of examination related to the urethral length or the type of the procedures you suspect?
Oh, okay. So I think what you're asking is that can you suspect the anatomy by the external appearance? Is that correct?
Yes, correct.
Yes. So the only thing I will say about that is if the labia are very small and diminutive, and
Yes.
the hole is very, very small, it usually means a much higher cloaca. If the hole of the perineal orifice is larger and the labia appear more normal, it's usually a lower type of cloaca. But I don't think I can answer in a more sophisticated way than that, because in either case, you're going to need to do a cystoscopy.
We have a question on chat about abdomen. Professor Osama Harabi said neurogenic bladder is the main problem rather than bladder neck in patient with cloaca.
Yeah, so in cloacas, many patients with cloaca have a very flaccid bladder. They don't have a lot of strength in the bladder to empty it. And that's why some cloacas need intermittent catheterization. The good news is that they almost always have a good bladder neck. So they can be a good intermittent catheterization candidate, and they can remain dry. Of course, you always need to check the spine, because maybe there's a tethered cord, and that's contributing to the neurogenic bladder. I see another question. Ali Ismail is asking about vaginal repair options. And I said I prefer the left colon, and my second choice would be a segment of small bowel.
Okay, Ulam, please need to comment.
What else? How high or low is your threshold for doing a Mitrofanov in babies who require CIC by Dhruv Ghosh? So that's a very good question. Honestly, I think a lot of it depends on the patient. If they tolerate intermittent cath, and if they remain dry for 3 or 4 hours between caths, then that's a perfectly good option for them. If, however, they leak at 2 hours, or they don't tolerate the cathing, then you have to do something. And then you have 2 choices. You either close the bladder neck, or you tighten the bladder neck, and in both cases, you do a Mitrofanov. But many, many cloacas can have intermittent cath. First of all, many cloacas can void on their own, but some need intermittent cath. Most girls tolerate intermittent cath very well. All right. So, Mohammed, I have to tell you, I've really been enjoying these sessions, and I'm happy to put some more on the calendar. And again, next year, April 1st and 2nd is the course.
Yes.
And April 5, 6, and 7 are surgical cases in Alexandria. And you're welcome to come for all of it. But if you just want to come for the course, it's on the 1st and the 2nd, a Thursday and a Friday. And then we'll do something fun on the weekend. Let's see. And Julie has just chimed in, inshallah, of course. We really, really hope, that that we can be together again next year, and the world is a better place, that we have found a vaccine, and we can get back to our normal life. So I will say Ramadan Kareem.
Allahu Akbar.
Really nice to be with all of you. And please, again, if we didn't cover your questions, please send me an email. My email I gave last time, but I will type it into the messages here. If I can find how to do that. But please don't hesitate. Here it is. I'm going to put it here. But don't hesitate to send me an email about your cases. Very good.
Thank you.
All right, have a good evening. Now, after this, now everyone goes to eat, right?
No, to pray. Tomorrow is the first day of the fasting.
Oh, it starts tomorrow. Okay.
Yeah.
So you ate already today, because I was worried that I was holding you back from your dinner, and I was getting nervous. So we're okay.
Okay. Thank you.
Okay, bye everyone.
Bye.